How are you? From wherever you are watching us, there is the People's Bench, and we are coming to you from Muthu Silver Springs Hotel here in Nairobi. Again, a very wonderful place where you can just come and relax with your family. And for much more, you can scan the QR code right on your screen. You will be able to get more about Muthu Silver Springs Hotel. I am your host, Fred Ogweno, and tonight we are talking matters health. I am privileged to have Dr. Ouma Oluga, who is the Permanent Secretary in the Ministry of Health in charge of medical services. We are here to look at some of the challenges, the progresses, the successes, and where we as a nation on matters health. But before then, he was very close to the Right Honorable Prime Minister Raila Odinga. He gonna tell us his relationship and how much more he knew Baba. Karibu sana daktari.
Thank you so
Pole
much.
Sana, my brother.
Asante, my brother.
Yes.
Yeah, it's been a tough time.
Very tough.
It's been a tough time since that date. Now it's 13 days since we got that news. And I can just say it's been terrible.
Very.
You know, for those of us that were close to Baba, you would wake up and sometimes you find this missed call, or sometimes on an afternoon like today, I was just in my office thinking, now Baba would have been calling me to Nairobi Club to have lunch with him. You know, I was one of those people that was very privileged. Baba used to just call me just to have lunch, and I would sit with him 2 to 3 hours. We're not talking much, and maybe I don't know whether I should say this.
Yes,
but
yes,
sometimes Baba used to call me, and you know, maybe he's in Serena, maybe he's Nairobi Club, maybe he's somewhere, and people are really waiting to see him. And then you tell me, no, let's just have us. Baba sometimes would want to relax by just having somebody like me around him. Because then now, you know, people think we're in a very serious meeting, but he's just telling me stories.
You know.
Yeah, and then we stand and then we are going. And then we're like, you've taken all our time. I'm like, I was just storying with Baba. If Baba wanted to see somebody, would have seen him. But that was my sometimes, and I've had the opportunity to work with him. He put me in his AU campaign committee. I went to NMS. He really supported us build the hospital. Now, of course, even where I am, it's courtesy of Baba. He gave me the opportunity to write the manifesto of NASA in 2017. If you've heard the term Baba Care, that came from me.
Oh, yes.
I'm the one who coined the term Baba Care, because Baba gave me the opportunity to write the manifesto of Azimio and Baba Care, and we had crafted it on social protection, which was the universal basic income, but also linking it also with health. Baba used to just ask me, what do we do? What do we do? And I remember it's sometimes very painful. You know, he sometimes would put me in rooms that are very difficult. I remember this time I was going to launch the manifesto of Azimio in 2022. And I had just briefed him. And then I think there's a team, Professor Makau Mutua, Professor Nyongo, Angilu, SK Mash, they also wanted to talk to him, and they had some ideas around health. And then he was like, no, you guys should go talk to Dr. Luga. And so I remember the whole team coming to meet me that, you know, Baba said we should talk to you, but they are saying it with like, why are we even talking to you? But you know, Baba, and I think Paul Mwangi also said this, but if Baba knew you are a professional, Baba would not go against your word. Baba would ask me, what do we do? You said, some people have come to my office here, they're talking about health. What do we do? And so I had a privilege, and that really stretched my mind also, because then you can't, number one, you can't lie to Baba. Number two, you really have to make sure that what you are saying is worth it. That if Baba says it, or if it is before people, it is worth it. And so I used to stretch myself, because much of my life I've also really invested in understanding health systems. But we are really broken. I personally am broken thoroughly. Baba was a good friend, but we used to laugh. We just used to talk. Baba would call me for long, sometimes buying for me omena there at Pumpkin. There was a restaurant there called Pumpkin. He said, Jarawila, come, just come, it's very nice. And then we'd just eat, just the two of us. Yes. And, not talking health, not talking government, not talking politics, not talking. And because I think maybe because I also never used to tell Baba, Baba, I want to be MPO, I want to be this, I want to be PS. Even this, to be honest, this position, I never ever told Baba, now, Baba, now I want to be PS. So I remember 19th of August 2024, we were in State House with him. And that's the day that his campaign was being started. And so that morning I'd called Baba and told Baba, Baba, we are voting for the WHO director, the Africa director. He was called Ndugulile. He passed on, the Tanzania guy. Now he's also another Tanzania. So I was like, and I know that you are also campaigning to be AUC chairman. Do you think that information can be useful for you? Then he told me, okay, thank you. He never replied. Now, when I went to State House, Baba was there, of course. It was the campaign, was the launch of his campaign. Then I think Suluhu was coming. Then I think they changed. Initially, Kenya wanted to vote for Senegal. But I think Baba, maybe because of the information I gave him, may have talked to the president, talked to Tanzania. So I was just told there by my minister then, Deborah, that, the Kenyan candidate has now changed from Senegal to Tanzania. And I think that was the exchange between Tanzania coming here to support him and that. So I think some of those simple things endeared some of us to Baba. And I never even told him. In December, it's now Honorable Junet who called me, told me, Baba said you should apply for PS position. It's different when you're told Baba has said
you apply.
Has said you apply. And I applied. And I didn't know people were saying, maybe he'll be PS Labor, maybe he'll be that. Then I was announced as PS Medical. But I've been also very passionate about medical services. I've been very passionate about health systems. We'll really miss Baba. Baba was Baba, not replaceable. It's a big hole in our heart.
Yes.
I want to take this opportunity to pass my deepest condolences to the family. I'm also fairly close to Winnie, fairly close to Junior. I'm fairly close to Mama. So Baba also enabled me to meet that family, often including interviews like this. The last time I was in Fix the Nation, I left Fix the Nation, and then Baba called me. They said, that was really nice. In Luo, Nyagem koro nyera nyera. Nyagem koro nyera, that one means Mamaida. Yeah. Yes. Nyagem koro nyera nyera batakai. Wacho maber kabisa. Nyagem koro nyera. So me and Baba, we had that kind of relationship. Like it's talk that is calm, that is nice, that is not about do this, do that. It's just about a father and a child, and this friendship, and he has faith in you, and I really miss Baba.
And my brother, there is one thing that people may not know really about Baba. People could see a very serious guy, but when you meet him,
Baba was nice.
He was so rich in stories. He would tell you a story even deep inside your village, Yeah. And just smiling, ever smiling. Baba was ever smiling, ever laughing.
Baba would tell me, like, up to where I come from, he would know And there's a time he even told me about my relatives, including my mother's side. I was like, how did you know? Told me, no, Jaka, I know. Yeah.
Even some of the old wazis that you did not know, he would tell you with their names, where they live.
Yes. Sometimes he would call them, now some of them, he would call me and tell me, oh, by the way, so-and-so is sick, is in hospital, you go take care of him. And I'm like, this is a mzee in the village that I'm like, this mzee Baba has talked to Baba. And even some of us, sometimes I would feel a bit embarrassed, like, hey, Baba, how? Hey, now now this is Mzee from my village. You know the Mzee is sick. Now me, I'm here, I'm looking bad, like I'm not taking care of the Mzee. But that's how Baba cared about people. He had very deep friendship. And Baba would listen to the very, very people, everyone. I know that because even there's a time I was doing COVID cash transfer in Nairobi. I gave 72,000 families money here. And Baba would call me and tell me, hey, there are people who have come here to my office. They're telling me you've given them money. Hey, that's very nice. That's very nice. We want that. We want our people to be taken care. That was during COVID and the lockdown. Yeah, so Baba, and those people are like down there.
Yes.
Like you would not even think these people would access Baba, but they would. And he would listen to them. And you know what? Baba would listen to those people sometimes even more than people in positions. And those people meant everything to Baba. And for me, that is something that I would want to embody even in my work. And I do in terms of a public orientation and citizen-centric. Like everything you do should be centered around the common good of people. And that was Baba.
Yes. And I remember anytime you were around Baba, anytime we could meet him, his phones, people were calling, the high and the mighty in the land.
Yeah.
But even those people who were there, the low class, so to say, and it tells us something about the leaders that we are having today.
Yeah.
You people in offices, in terms of your reachability.
Exactly.
It was so easy to reach Baba that it was easier to reach him than even reaching an MCA.
That is true.
From the village. Just meeting a member of parliament or a PS like you would take somebody almost a century to meet.
That is true. Baba was accessible. And, it's interesting because Baba would be accessible for us in high offices. Baba would be accessible. He would call the president. At the same time, he would call somebody in the village.
Kibuye.
And somebody in Kibuye. And he's talking to somebody in Kibra. And he has talked to somebody in Madare. And he has talked to Amze. And he has talked to some veteran person. Even now, the amount of people who tell you, oh, I spoke to Baba, it almost became like a contest. But it is true. Baba would call people. Baba, if you, like I called Baba, and then he didn't pick. The following day, Baba called me. And we were just talking. We were not talking about, there was no issue. There's just talking, like that, He used to ask me, Dr. Chedinade. Yeah.
And tell me, Dr. You were among those who accompanied, the team that went to India.
Yes.
How was the mood like inside that plane as you were going there, imagining that Baba is no more?
Yeah. In fact, when that morning I woke up, I called Ogeta, Maurice. Yeah, that Wednesday morning. I usually have a meeting with all my hospitals. So I woke up 6:30. I called one of the CEOs, Dr. Lesiampe, the CEO of Kenyatta. I told him that you will need to chair the meeting on my behalf because there's something. So I had called Ogeta. Then Ogeta told me we woke up well, but now things are not okay. Mm-hmm. Then he cut the call.
That was around what time?
That was around 6:30 Kenyan time. Yeah, it was around 6:30 Kenyan time. Then I called him again, he didn't pick. I called him again, he didn't pick. Then I tried Baba's number and he didn't pick. And then a few minutes I saw Nani calling me, this guy Okech Sala, calling me and telling me, hey, Daktari, there's a problem. So I left, and then I was just driving towards State House. I was like, when I reached, in fact, I didn't even talk to the president. I reached State House, they opened for me, I got in. I saw the president also on call. He was a bit busy, but I think he had the news already. So I think from what I could see, then I just left to Karen. When I went to Karen, among the first people there was, of course, now people were trying to swell. I stayed there from around, I think I arrived in Karen around 8 a.m. I stayed in Karen from 8 until around 10. I think Mama had gone up, so we were just waiting. But now, of course, at that time, we had now confirmed the news. Now, I had now talked to Ogeta again. He told me, Bana, the unthinkable has happened. Yeah, he was just crying on the phone. Now Ogeta called me back, I think around a few minutes to 8, told me, Bana, Baba is no more. So even me, we were just there, we were crying. Then, so, in that moment of confusion, people started coming a lot. So I was like, hey, this place, we need to start organizing things. So I was like, no, we need to start putting a barrier so that we start to control this. No, it's not overwhelming, because leaders started streaming in. So you're crying, but you also like, I'm the one here. I'm the one to do things. You're the one. So immediately I called Raymond. I told him, I'm here, and we may need security. We need to beef up security. We need to do this. We need to support the guys on the barrier, if you know.
Yes.
So I started doing things. And then, so now people came. I think the president came around 11. We were there. When it got to around midday, Mama called me and told me, I want you to go to India. And then, of course, the president also told me, I want you to go to... In fact, I was the first person to be told to go to India. And I take it as a great privilege.
Yes.
I know I was very close to Baba. Yes. But the fact that Mama also could identify me and tell me in person that I want you to go, it meant a lot, yes, even in that moment of grief. And that the president reinforced it also, told me, PS, nataka ujipange, uende India, mlete Baba.
Yeah, I knew how close you were with Baba.
Yeah, so I think then they knew, sometimes it's not, you
like
can
Baba's
be very
son.
close to
Yes.
somebody, but it's not every day that people know that you are close to
Very
them.
true.
And so it was very emotional for me. First of all, I was just going to check, is this Baba really dead, or this is just stories? Now, of course, we arrived there in India. The whole journey was very solemn. It was I just cried throughout the flight. I remember sitting next to Murkomen. He just kept telling me, PS, I'm sorry, it's okay. I'm sorry, it's okay. I couldn't believe it. When we get there, then I had to go and do paperwork. Now when the India government is now handing over, I had to go now do the sign. So we divided our two teams. So there's the team led by PCS, Musalia Mudavadi, Opio Wandai, and Joho, Murkomen, and the family, Jaoko, and there's Kevin that we went with. They went to now the side where they were now receiving the casket and making sure it gets. Me and gone to the launch together with the generals from India. Baba was brought to Mumbai by the aircraft of India, and so now I had gone to do the paperwork. The
paperwork.
Yeah, which was also very emotional. That now in terms of paper, now it's me who was being handed over to. I felt so bad. Yeah, it's still.
Sorry, Bwana PS.
Yeah, so. It's okay.
And when you arrive in India, sorry, Bwana PS. It's okay. Yeah. It's okay. We understand. You arrive in India. Were you able to see the body?
No. It was already wrapped in a basket. Yeah. Sorry, I'm sorry.
It's okay. Help us with that.
Yeah.
Sorry, Baba is gone, and that is life. There is a time that God had given him. to live with us, but his legacy. Yes, you can. Yeah, just give it that to him. Thank you. Just to.
Sorry.
It's okay.
Oh, I'm sorry. I'm so sorry.
It's okay.
So,
It's okay.
it's gone, man.
Baba is gone, but his legacy will live with us.
Yeah.
One thing that you remember Baba for before we change gears, Dr. to matters health.
Yeah, Baba was, oh, come on. Baba was just kind and nice, and Baba was very welcoming. He was, for, so as I mentioned, I don't know about, everyone has a different relationship with Baba, but for me it was, Baba was more like Baba. I lost my dad long time ago. And every time I was around Baba, it was more like you are around a father figure. It was never about work. It was never about all these things.
And how he loved professionalism.
He did.
I remember.
There's no day Baba asked me, I'll do this. No. Baba always asked me, I have these people, there are some hospitals here, the owners have visited me. They're telling me ABCD. Then he would ask me, what do I tell them? My relationship with Baba was very different. There's a time he had asked me, there's this challenge about doctors. That was last year, 2024. There was a long strike. I think Davji and the team had gone to see him in his office. They had just from seeing the president, and Baba called me. They were still there, but he called me aside. Told me, I have these union leaders here. They have come to me about these issues of doctors. What do I tell them? It's not as a very privileged position.
Yes.
Yeah. So that was my relationship with Baba.
Yes.
What do I tell them? What do I do? They say, there's this team from Germany visiting me here. They are telling me they have this idea. I want to send them to you. So that was always there. So either Baba would send somebody to me to listen, or he would ask me, what do I tell them? That from long time ago. Yeah. So it was a very.
Thank you. Thank you. And with that, we are shifting gears, viewers, from wherever you are watching us. Remember, there is the People's Bench. We are coming to you from Muthu Silver Springs Hotel here in Nairobi. Please, I would like to remind you to kindly subscribe on the channel so that anytime we have this kind of candid conversation, you will be able to get the notification. And now we are shifting gears to matters health. Something that was very dear and very close to Baba Raila Odinga. It was very close to his heart. We are here with PS in charge of medical services on matters health. We want to debunk this thing, SHA, she, and all these things, Daktari. We don't know even the name, the right name, and you are here.
You know the right name. You are trying not to know the right name.
I do not know, so that you may tell me.
You know the right name.
Yes. Thank you, Daktari.
Yes, sir.
This SHA, this she, would you kindly tell us? People are saying that it is not working. Others saying it is working, and others say that it only works for you and President William Ruto. What is the real situation about SHA?
SHA is working. SHA is one of the best ideas that we've had. So just two things. One is that health is the most important thing you will ever have until you don't have it. Now, everything is very important. Coming to this podcast, doing all these things. In fact, even now talking about Baba, even politics is very important. Until the day that you're sick, then you realize you can't do any of those things. So it's very important for people to know that health is the most important thing that you will ever have. Now, basing on that, a country must decide on how they want citizens to enjoy health. And for you to enjoy health, you must protect it. For you to protect health, you must find a way of when somebody is sick, they pay for it. Now, health financing, the mechanism that we have key priorities, but health financing is one of the key priorities. Right now, we have donors that are pulling out. The US government just stopped work. Now we are renegotiating for them to come back. Foreign Commonwealth Development Organization, or the UK, has pulled out. Danida is ending. That alone is a lot of money in health. Now we must find a way of having our own resources so that we pay for health. So SHA is the organization. SHA is just like KRA or like HELP. SHA is the name of the organization that is doing the work. It's called Social Health Authority. Okay, it's the name of the organization. Now within SHA, there is 3 legs or 3 funds. 2 of the funds are from taxpayers or from taxes. The primary health care fund that pays for services in level 2 and level 3. That's basic services. And the emergency chronic and critical illness fund that pays for the big problems. So dialysis, cancer, ICU, accidents. Now, if you look at these things, I'll summarize them. Basic services are services that every single human being, just by the fact that you are Kenyan, the fact that you are Kenyan, should get. That these are services you should never ever be denied, irrespective of how rich, how poor, how sick, how healthy you are. They are called primary care services. Level 2, level 3. Now, then there are some things also that it doesn't matter how rich you are or how poor you are. If the government does not pay for them, you'll either get very poor or die. Okay? So, for example, dialysis. Dialysis costs 1.2 million shillings per year. One session is 11,000. You do 2 sessions, that's 22,000. 2 sessions, 22,000 a week. Sometimes you do 3, but let's say 2. In a month, that is 88,000. 88,000 by 10 is 880,000. If you want to add plus 160, you're doing 1 million. Okay, 1 million plus the small things that you will buy, which is around 1.2 million. Now, if you take any ordinary Kenyan in the village, any ordinary Kenyan, even if you had cattle, even if there were 20 cows that you had, and you had land, you will sell your land within 1 year. You have just paid for dialysis. Now there is no more land to farm. So there are things that if government does not pay for, it doesn't matter even if you are working, even if you are earning a salary, you will either get very poor or die. Those are the things we are paying for from the emergency chronic critical illness funds. Okay? So that we protect, even if you're earning salary, we protect your salary. You continue earning your salary so that you pay for your children's school fee. You can do some other thing. You don't sell your land. You don't sell your cows. You don't sell your goats. You don't sell chicken. Because you can sell those things, you will not even be able to pay for it in a year. If you get cancer, for example, we have the 5 commonest cancers in Kenya. Cervical cancer, breast cancer, prostate cancer, then colorectal cancer and esophageal cancer. Each of those cancers, treating them costs between 200,000 and 600,000. Okay? If you take the poorest Kenyans, for you to get 300,000 or 600,000, you will sell everything. Even if you got better, there's nothing to go back to. So those are the things the government is paying for through taxes. Then now there are some other diseases that they will not get you very poor, or you will not die immediately. You have time. So for example, you have a knee problem. It gets worse by age, but a knee problem may not kill you. Okay? So those are the ones we want Kenyans to contribute. Now that contribution is what we call Social Health Insurance Fund. Now that forms 3 things: Primary Health Care Fund, Emergency Chronic Critical Illness Fund, and Social Health Insurance. Either you are employed like me, so the government takes money from your salary, 2.75%. This 2.75% is not just for me, it is also for the person who is not able to pay. It's like an arambe. It's like we are doing an arambe. So, because if you get somebody who is sick in my village, they may call me and tell me, hey, PS, I am so sick, please help me. And that happens all the time. I can contribute 10,000, 20,000, whatever. Now, there's another Kenyan who does not even know a teacher, an MCA, does not even know anyone who is working in their village. The poor of the poorest. Now, they have no one to call for this Arambe. Now, this social health insurance fund is our Arambe. Sisi wote kama wa Kenya. Now, we have a population of around 20% that is employed. They earn a salary. Those are the ones we are taking money from. Then we have another population of 40%. People like Ogweno here, people like Boda Boda, Mama Mboga. You have income, but the income is not through salary. It may be TikTok has paid you something small, or Facebook. It may not be consistent. Sometimes you get it, sometimes you don't get it. But either way, you get it. You find somebody farming goats in Kajiado. They may sell goats. In 3 months, they have sold goats worth 40,000. Another person is having cows somewhere in Samburu. They sell cows worth 200,000 in a year. Maybe they only sell in August. So January to July, they don't have, but they have sold. So they have income. Okay. Now, this is 40% of Kenyans. You find somebody is farming cassava. They farm cassava. They have some cassava in 3 months. They take it to the market. They get it. So we also want those ones to contribute. Now, those are the ones that now we take through the social health insurance fund. So there are those ones that are working. We take the salary. These other ones, we want you to contribute through a mechanism. Then there's another 40% of Kenyans who they can't pay, they won't pay because they are very poor. Okay? Now, those are the ones we combine the salary, the people who have brought in the salary, the people who are selling in the market, whom we want to contribute. When they contribute, all of this money forms support. Now, even the one who has not contributed, we can pay for them healthcare. And there are many Kenyans who cannot contribute. We have around 4.3 million families that cannot contribute. These are the ones also we are asking for sponsorship.
I hear you, Daktari.
Yeah.
I hear you. You explain it and it seems so good. But Daktari, right now I walk, for example, to Mama Lucy Hospital. The very first thing I'll be told there to pay some amount for registration. I don't know whether it is for registration or what. Then from there, if it is something that needs some examination or some blood sampling to be taken to the lab, you have to pay for it. After that, getting the lab, results coming out, after you paid for it, you will be told to go and buy medicine. So if this thing is working, I'm asking for on behalf of the Kenyans who are watching you, because that's why you are here to clarify. This amount of money that I've paid, this 100 or whichever amount for registration. And remember, I'm still contributing for that SHA. And then the 2,000 that I've paid for the lab, because I have to pay for it. And then after that, you are told to go to the pharmacy. You are told there is no medicine. By the time you calculate this thing, you realize that I will have walked out of Mama Lucy Hospital having paid 5,000 and more. How is this thing working?
If you are contributing, and I'll repeat that, if you are contributing to the Social Health Authority through the Social Health Insurance Fund, if you are contributing and Mama Lucy Kibaki asks you to pay something, that is fraud. If you are not contributing, okay, you are not contributing, that means you are not a member, and they have asked you to pay, that is not fraud. That is why we want you to pay, and what you are going to pay is less. Now, we have had challenges, and the challenges are with the hospitals mainly. You know, in the NHIF, the challenges used to be with the patients. Now we have the challenges with the hospitals, but we are sorting it out. One is that some hospitals, because of what I've mentioned, called fraud, they were trying to resist, but that is now ending. So you go there, they know that you are a member of SHA, they are going to claim from us, but they are also trying to force people to pay. That's why you have seen us closing hospitals, and you saw us close 738 facilities. You have also seen us list some facilities that are now under investigation by the DCI, and there are others that have even been prosecuted because of that. Now, since we did that, this problem is getting less and less. Now, some hospitals are refusing, saying, no, me, I don't take SHA. Yeah? Even those ones, we are coming after them because you cannot say that you are registered, your license, a Kenyan has come, you are denying them service. Even the Constitution, Article 43, does not agree. So there are two things. You can have people, it's like coming to hotel. Like now we are in a hotel. You can have money to buy food in a hotel, but the hotel either has refused to give you the food or the hotel does not have the food. Now, SHA is just a way of getting money to pay for the food. Okay? Now we have started working to make sure the food is also there. Because initially we had said, okay, these hospitals, let's give them benefit of doubt. They are good. They have the interest of Kenyans. They will do well. But we've realized that's not ordinarily the case, including some public hospitals. Now, I have a meeting every Wednesday, and I told you, I have a meeting every Wednesday with hospitals, every Wednesday, to make sure that what SHA has said they will pay for, those hospitals can provide them. And we are slowly closing this gap. Now, there is also another challenge, and I mentioned, for example, cancer, where we have a number of cancers that SHA has said we are paying 600,000. Okay, then you get another cancer that may be costing 10 million. So SHA will pay the 600,000 because that is what we have calculated average. When you do insurance, you do what we call actuarial, or you do a calculation based on the amount of money available, the population, the diseases that are there. But then you get outliers. Outliers are the rare cases. So you find 5%, for example, of cancers are beyond what SHA says they can pay for. The numbers, from a statistical perspective, may be less. But when you are the one, that time you are in Mama Lucy, and you are the one with that problem, it's not less. So you will find, for example, every single day, we have around 4 million Kenyans going to hospitals, whether it is in Busia or Turkana. If you combine all hospitals, like Kenyatta alone, we have every single day around 5,000 people, either in the outpatient, we have 2,000 that are admitted. MTRH alone, every day, we have around 6,000 Kenyans there, 4,000 that have come for clinics, and another 1,400 that are admitted. Now, you will find that out of these people, these 4 million Kenyans, SHA will work for 3 million. I hope you understand.
I'm getting you.
Now, another 500,000, somebody has made a mistake. The hospital says, oh, SHA is not working, but SHA is working. So they will call our call center, like 147 if you call, then the problem will be sorted. Another 500,000 may have a challenge. Either they don't have an ID. Like yesterday, I was being called about a case in Kericho, where a girl has gone to deliver. She is not yet 18. She is just about to turn 18. SHA says, we need your ID. Okay? Now, the Ministry of Health has a solution for it. We want to give a temporary ID, but it is a Sunday. So this person has gone there. Then they find either the hospital people are, and I'll have to say this, are lazy. So you find they are not there. The people who are supposed to make the decision may not be there. So the doctor is there, the nurse is there. They want to treat, but the person who is supposed to give the temporary ID is not there. At that particular time, this person who has brought the patient or the patient is very frustrated. They're like, no, this SHA is not working. But the problem is not SHA. The problem is at Kericho Hospital. I hope you understand.
I'm getting you because, Dr. Isn't it a matter
so now,
yes.
But you see, this Kericho Hospital is managed by the county. It's not managed by the Ministry of
Health.
So this person has to call Oluga. Oluga is also not directly in charge of Kericho Hospital. So then I have to look for the CEC, the chief officer. I even ended up calling the county secretary. But these are problems because not everyone takes their work seriously. Now, Oluga takes his work seriously. I have sorted out SHA. I've said, okay, now people who are not 18, we have a way of dealing with you. People who have this problem, let's say today I had another issue, let's say at Nairobi West, where the patient can easily be treated. Nairobi West wants 1.1 million. SHA has said we are going to pay 600,000. So instead of the hospital being straightforward and saying, this procedure will cost 1.2 million here at Nairobi West, SHA will pay for 600,000. They start telling you that, you need to pay us 500,000. So then you start asking, no, but SHA is going to pay. So they don't tell you that the procedure is worth 1.1 million. They are going to claim 600,000 from SHA. You add us 500,000. Yeah. So if they told you that SHA is paying 600,000, but we are charging 1.1 million, so we want you to add, it's different. So that you make the decision to go to Kenyatta National Hospital where SHA is paying 600,000 and you don't have to add anything. So this is some of the mischief we are dealing with. And it is coming out, SHA is not working, SHA is not. But it is mischief of hospitals. That's why you see we are very tough on hospitals now, because we must fix that problem.
I hear you. Tell me, Dr. Is SHA supposed to cover laboratory services?
So what we have done is that SHA covers services. We have not disintegrated what we call unbundling. Unbundling means that you open up. So for example, if you go and you're being treated for malaria, SHA will pay for your treatment for malaria. SHA will not say that your laboratory malaria is this, your medicine for malaria is this, your doctor consultation for malaria is this. We pay for malaria.
The reason I'm asking you that, Daktari, is that I've worked as a journalist.
Yes.
I've worked quite a number of hospitals.
Yeah.
And when you walked in there, after you have paid registration fee, you are being sent to go and see a doctor.
That is fraud, because, and I know what you're saying.
And it is happening as we are speaking.
Council of Governors has come to us and they have said we do what is called unbundling. Unbundling means we open up the service and say that, okay, now this SHA is going to pay this for the doctor, is going to pay this for the laboratory, is going to pay that for your medicine. We are not going to do that. What is important for us is to have what we call value-based healthcare. Value-based healthcare means that you are treated as a whole. So there is a bit of a problem. And in fact,
are we going to have it, Daktari?
I'll tell you something else. We went to Kakamega. And now we have digitization. I'm going to talk to you about digitization in a short while. We went to Kakamega. So in Kakamega, we found 52,000 patients had been seen in Kakamega PGH. Yeah? Only 9,000 of them had been given medicines. We can see what hospitals are doing because we are digitized the entire system. There's everything we can see. Now, 52,000 people, the doctor prescribed, but the hospital did not give me medicine. Okay? But the hospital claimed for the service. They said that Oluga was admitted. We treated him for 5 days. Please pay us 40,000. You're getting the point? That 40,000 includes the medicine, which they did not give. Now, this is the mischief that is also there with the laboratory. So they say that, okay, now what they are trying to do, they say that before we admit you, go to the laboratory. But you see, we are going to admit you. Why are we going to admit you? We are going to admit you because you have malaria or because you have a problem. For them to find out that you have malaria, they must do the laboratory. True or false? Now, in SHA, we have what we call the benefit. So we say malaria, we are paying for 50,000. They say that. Okay? Now, for them to find out that you have malaria, they have diagnosed it. For you to bring for me a claim that this person has malaria, you have diagnosed. So why are you charging them for the laboratory?
That is the question, Daktari. That is the question. Kenyans are paying for laboratory as we are speaking right here.
That is fraud.
And when are you going to go for them?
We have gone for them. You have seen us send 1,800 files to the DCI.
That has been sent, but even as we are speaking, and those who are watching this, because there is the people's bench, we get feedback from the people.
Yeah, and we want the people to help us, and we are going to go after more because we have to streamline the health sector. And I'm not saying that SHA pays for everything. No, there are some things SHA doesn't pay for, and that is true. And things that SHA does not pay for. We are very clear SHA does not pay for this. And the hospitals, I say, can be very forthright with Kenyans. If you call 147 and they tell you SHA does not pay for this, we will also confirm for you SHA does not pay for this.
And Dr. As you walk, sorry for interjecting, as you walk inside that hospital, why don't we have write on their notice board, or whichever place, so that you are able to write it, this is what SHA does not pay for, 1, 2, 3, 4, so that these people are able to check and hold those people accountable, if at all, lab is supposed...
SHA is like your anchor.
Yes.
SHA is like your anchor that you have called to pay for you something. Now, the hospital belongs to the county or to the private person. And there is a bit of a challenge here. So we want to put on some notice boards about all services. Like we had agreed with Governor Sakaja here in Nairobi to put in all the hospitals that this is, you will walk in, walk out, no cost. I don't know whether they have done it. But there are some counties that we had agreed with them to do that. But you see, SHA cannot come and put in Mama Lucy because Mama Lucy does not belong to SHA. And I want Kenyans to understand this. When you do healthcare system, we have to separate the functions. Now, what we are trying to work with through regulation again, now regulation is the person who registers the hospital, the person who registers the doctor. Now, this is now regulation, the Kenya Medical Practitioners Dentist Council. We are trying to make sure that hospitals comply with what SHA says, because SHA, their work is just to pay for the service that you provide for.
Thank you, Dr. When I pay, or that widow who is paying for SHA, back in the village, what matters to her is that she's paying for SHA. Whether SHA has an arrangement with the county government, whoever is managing the hospital, that does not matter to them. What they ask is that I'm paying for SHA, and I expect to be treated.
And I think what Kenyans have to give us credit for the first time we're having this discussion, and we are the ones who have unearthed it. And we've done very well. And by the way, hospitals have also done very well because there's something called change management. SHA is 1 year right now. 1 year. 1 year. Now, NHIF, which people often talk about, only contracted 3,000 hospitals. So there were very few hospitals NHIF was working with. Majority of hospitals NHIF was not working with. Now, SHA has said all hospitals. So now there is around 6,000 hospitals that did not even work with NHIF that are now, so they are learning what we call systems of insurance.
Thank you.
And we are now trying to do the change management so that they are aligned.
Thank you, Dr.
And I know that in another 6 months, you will not have these problems.
Thank you, Dr. One of the reasons that made this government to come up with SHA was to cure corruption.
That's true.
And I remember President William Ruto saying that unlike the way things were happening during NHIF, things are now going to change. The hospitals that used to
defraud.
Yes, defraud the government. But we look at the list, we look at the report, when your minister Duale was talking the other day, it's like we transferred corruption in a monumental manner from...
No, and I'll want to say...
If it is not, then why have you taken these people to court?
Listen, have you ever seen people being taken to court through NHIF? Now, first of all, NHIF was manual. Manual means that you go to the hospital can cook any data, they can bring any report, and NHIF was paying. Now, NHIF did not have a way of checking whether what the hospital has brought as a file, that paper they brought, was correct or not. Now, SHA is very different. When Oluga or Ogweno goes to the hospital, okay, you have to start the journey. So first they enter your ID. You go see the doctor. They give you the diagnosis. They give you the treatment. They give you the medicines. That is why I've told you, as at now, we know that 52,000, did I say that? 52,000 people went to Kakamega. We have seen that they went through and only 9,000 got medicine. So already we have seen there's a problem. You're getting the point? Now, this is data. Now, when this data comes, you have gone to hospital, I've gone to hospital, I've gone to hospital, he has gone to hospital. Collectively, in 2 weeks, I get that information. I'm getting the point. Then I can know, this hospital is mischievous. Okay? I get it after, but I can get it. I know that Oluga went to this hospital, then Oluga went to this other hospital, then Oluga went to this other hospital. Then I check, why is this one person going to 3 hospitals? So what is it that was not here, that was here, that was here? Then I find that it was one doctor who referred him, because the doctor's name is there in the system. The doctor who referred me is there. So I can know this doctor is fraudulent. He transferred, instead of treating Oluga in this hospital, he transferred Oluga to his private clinic and then transferred Oluga to another private hospital. Now, when I see that 2 weeks later, I can now go after the doctor. This was not possible in NHIF.
I hear you.
So now SHA is actually meant to cure fraud. And by the way, you've seen the amount of cries have gone down. So you see the hospitals, they were always crying. After we took them to court, after some of them have been charged, right now I think the prosecutor is preparing another round. Have you seen the noise? There is no noise.
I hear you, Daktari. Tell me, medicine or availability of medicine is part of medical services. When are we going to start having medicine in the public hospitals, pharmacies? Because you go there, you are tested, you are given treatment. When you go to the pharmacy, you are told there is no medicine, and it has been like this for decades.
I almost will read for you a message I was getting here about, this is about Wajir County, where 2 weeks ago they ordered for medicines. 9 days ago we delivered medicines. Out of the medicines that they ordered for medicines worth around 180 million. Out of the medicines that they ordered for worth around 180 million, we've given them medicines worth 130 million. That's 76%. So right now in Wajir, people should be getting 7 out of 10 medicines that they are prescribed for. But there is a problem that we are also solving. Now, for long, the Kenya healthcare system, and I know it very well because I've been in this sector for so long. I have dedicated my whole life, 15 years, to studying healthcare systems. And I understand it like the back of my hand. There's a problem between the doctor, the nurse. When you're seeing the patient, what the doctor and the nurse prescribes is very different from what the hospital has ordered. Right now, we even have hospitals that have medicines that have expired. Because the hospital pharmacist or the person in charge of medicines in the hospital ordered for medicine, the medicine was brought from KEMSA, but that is not the medicine that the doctor prescribed. Because sometimes we have a problem, doctors, nurses, and we are now curing this. And I've been in the sector, so I know what I'm saying very well. Thinking that medicine is not there, because that is what they are used to. So now we have revamped KEMSA, we have put in money there, we are now reviving it. But you will find the doctor in Wajir is still prescribing medicines that are not the ones that were ordered and brought. So for example, if you want to treat pneumonia, you can treat pneumonia by a lot of medicines. You can treat pneumonia by prescribing ceftriaxone. But the medicine that the hospital has ordered is maybe cefotaxime, something like that, okay? So you find that there is a disconnect between the medicine that the hospital ordered and the medicine that the doctor or the prescribed. For 2 reasons. One, because these 2 people don't talk to each other. So I've now formed a formulary committee in every hospital to try and solve that problem, so that the doctor who is prescribing is aware about the medicines that have been ordered, so that they change their prescription to suit the patient. That's one. But it is work in progress. You know, if you have 59 years of a rotten system, changing it is not easy. And we have found even today we were doing our report, and one of the things that we were talking about, the older clinicians or the older people, it's very difficult for them to change. Yeah. So they are used to, for example, prescribing gentamicin. Okay. But that gentamicin is now, for example, outdated in the guidelines. So the Kenya guideline has changed, the way Kenya wants, for example, pneumonia to be treated. So we are now putting maybe another medicine there. Okay. Now, the older doctor does not want to prescribe this newer medicine. We are even finding that problem with cancer. And again, I'll say this because it is part of the biggest challenges we are having. So you find somebody has prostate cancer. This is somebody who is very poor from the village. We have medicines that can be prescribed for cancer, which we have put in the guideline. Then you find a doctor, a very specialist doctor, because they are not keen on the social status of the people. There is a bit of, when I was in medical school, they used to teach us about, social medicine. Social medicine is about the surrounding, where this person comes from, the kind of house they live in, the kind of relatives they have. So you find that doctor is prescribing a medicine. One tablet is worth 140,000. But this is a very poor person in the village. Yet there is another medicine that is worth 38,000, which we have put in them. So these are part of the things we are now solving, where we have said, SHA pays 600,000 for cancer. We know that if you prescribe this medicine, for example, we signed with Roche the other day, that if you prescribe this medicine, it's 38,000. So this 38,000 can go for like 10 treatments. It will be still 380,000. You find that doctor prescribing a medicine that it's not even in the country. It has to be found from South Africa. This is somebody in the village. They can be treated. It's not that you have tried this medicine and it has failed. Yeah? Because of excitement, maybe they went for some conference. They want to show that they are the brightest, which they are. I am also a very good doctor. So you find they have prescribed medicine worth 140,000. So then, somebody else has also a chemist outside there. Maybe the doctor also knows the one who has a chemist. So they go there, they buy this medicine for 140,000. 3 treatments, they have already finished their SHA cover. Yet, there is another treatment that could have covered throughout.
I hear you, Doctor.
And these are I'm telling you, the health system things. And I know it is very difficult for Kenyans to understand these things. I know it is very difficult, but that is my work.
Yes.
To fix that problem. You, and I am fixing it.
Yes. And thank you for creating time. I still have 2 questions, but I beg that maybe you do it in 30 seconds, if you can, because I know you've done that before. Yeah. What is this noise that we are hearing about overseas treatment? Whether the ministry has stopped it, it is there, and Kenyans are stranded in India.
The ministry has not stopped overseas treatment. The Auditor General wrote a letter to the Ministry of Health and to the Social Health Authority that for you to continue doing overseas treatment, you must put a criteria of contracting the hospitals in India or anywhere else in the world, of agreeing with those hospitals in terms of what you're going to pay them. NHIF used to be a free for all, where you find big shots or big people being paid for 3, 4, 5 million. A poor Kenyan cannot go. So this is the system we are stopping. We used to pay India 10 billion shillings every year. So the Auditor General is the one that has told us, wait a minute, stop. Okay? But it is also, the Auditor General is also right. So SHA, I personally, Dr. Luga, PS, I have written to PS Foreign Affairs, who has also written to the Kenya High Commission in India and other high commissions, so that they can write to the government of India and say, are they interested in working with SHA? Then we can contract them, and then the services can resume. So that we are sure that whether it is me, whether it is an MP, this is the maximum that will be paid for this service. That hospital is contracted. That system never used to exist. We are fixing
Don't you think that it would have been more helpful, probably, to consider those Kenyans who are already in India and other countries, so that
the Kenyans who are already in India are being handled case by case. The Kenyan High Commission in India is already on that case. They have already identified the list of all the Kenyans. The Ministry of Foreign Affairs are identifying them. Now, there are 2 other things. When you go to India and SHA pays, you should have already come here with a letter that SHA will pay. Okay? There's something called a letter of undertaking, which was being done through the Director General, Dr. Amoth. Now, there are many Kenyans who go to India, they get stuck in India, and then they start saying, oh, no, SHA is not paying for me. Yet, yes, we know. Health, unfortunately, is very emotional. So you show people are suffering, somebody has lost weight, somebody is having, they even may have passed on, but they didn't follow the procedure. That is the biggest problem we have. Then now, at that particular time when Dr. Luga comes to talk about the procedure, then now, oh, this Dr. Luga is not caring, these people are not, but you didn't follow the procedure. And now when like tomorrow, I am facing the Public Accounts Committee. When I go to the Public Accounts Committee, and this is Kenyans' money, they don't know that I was trying to help. They just like, did you follow the procedure or no?
I hear you. Tell me about this means testing tool. Daktari, a widow in the village is being told through that means testing tool that he has to pay 1,200, 700, and President promised that they were not going to pay anything, or the least was to pay 500 shillings.
Do you know the interesting thing that we have found out about Kenyans? There were around 1 million Kenyans who are being given money every month. These ones of 2,000 shillings, the elderly people. Do you know who are the elderly people?
Tell me.
I tell you. A minister came to the cabinet and said, my mother is part of those 2,000 people. You know, the way Kenya had been before, Kenya had been a very bad country, where Oluga goes to the village. My mother is getting above 70. I have a salary. I have a bit of means, I am able, but I put my mother in the list. Are you getting my point? Now, I am locking out the poor Kenyan. And when I was doing cash transfer program, and just give me a minute to explain this, in Nairobi, I went to the slums in Nairobi. That time was 2021, 2022, during COVID. You know, in Nairobi, when you go and tell people, there's a program, I am coming here to help people because of COVID, people who cannot. People were full of halls. I was there with MCS and then chiefs. Then I realized this is not the best method. Because the people who have come here that they can't are the ones who can walk, are the ones who can hear what I said. They are the ones who have even been mobilized by somebody else to come. Then I changed the method. You know the method I used? I went to the community health workers, community health promoters. I told them, check for me the people who are in the houses who cannot come, who do not even know Dr. Luga was in Kibra trying to look for people, who cannot access the MCA. They gave me list. I got a list of 326,000 people, the whole of Nairobi. Then we went through a criteria. That criteria was 11 questions, the kind of house you have, education, whether you have disability, income, you know. We got 72,000 people. I was given an award internationally for this program through the World Food Program.
Congratulations.
Now, the means testing is a perfection of this. The means testing means that we want to help the poor of the poor. Now, we have people who they pose as poor, but they are not poor. And it's possible. So you may have somebody who, even let's say my sister, they may not have a work, they may not have something, but I send for them money. I hope you get what I'm saying. So they have some income, okay? Then, you know, when you do the means testing, you can tell, this one, from the M-Pesa they receive, this one can afford 500 shillings a month. Are you getting the point? Irrespective of the source, this one can afford 500. There is somebody else who can't. Now, if you put a flat rate, then unaumiza wa Kenya. And that is what has been a problem here in Kenya, where the people who can rush to take government things, and the people who can't. I went to Kibra. People, you know, they have a child that has epilepsy. They are in the house. They don't even know anything. They have people with disability. They are old people who are in this Nairobi. They don't know any other village to go to. Yeah. But the one who can rush, the youth, the young people, they were full in the hall. Oh, I want to be registered because they want to get the 4,000 shillings. But the one who can't, that's why we've introduced means testing. Because the Mama Mboga and the person who is selling goats in Kajiado are different.
But how accurate is it, Daktari?
It's extremely accurate. Now, I know there's a challenge. The challenge is that there are people who, they are doing business. You are in a shop, let's say you are selling mtumba. So, people send for you money in the phone. It's not your money. It is business money. But you are using your phone. Are you getting the point? Now, at that particular point, those ones are things we call teething problems. So it tells you that, you need to pay us 10,000 shillings in a year. Because we see your M-Pesa, we see your KRA, we see things. So then you're like, no, me, I'm a poor person. Of course, it's true, you're poor. Because maybe this is money for business. It's not like the total income, okay? But now that is also why we want to streamline things. That's why there is now other government programs like Nyota, so that we teach people how to do business. So these are the challenges we have. Maybe you are chama. Let's say you have a women chama in the village. So women send for you 200 shillings every week.
Yes.
Okay? So you get money on M-Pesa. The government thinks, you are gonna pesa. So you get a higher one. But if you come and explain one by one, then it is sorted out.
Thank you, Dr.
Yeah.
There is only one Kenyan ID and one Kenyan passport, even as we are winding up. Does it concern you and pains you that young babies were dying in Kiambu County because the county government and the union leaders could not agree whether it is the responsibility of the county government? These were Kenyans, these were young babies who died, and the ministry, you people are just there, you were doing nothing about it.
We were not just there. Go to, there's Nation Media and also Spice. Kiambu County government even accused the Ministry of Health of meddling with the affairs. You know why they were accusing us of meddling with that? My name was specifically mentioned. Because I called the CEC, Dr. Maina. I called the chief officer, Dr. Nyaga. I called the governor. Even recently, when they got into an agreement, I usually don't like taking a lot of credit, by the way. Even recently, when they went, Abdul Somad is my very good friend, the governor of Mombasa. And he's now the chair. And I'm very happy because Abdul Somad, before he was even voted, he came to see what I was doing here in Kibra. And he asked me, what can we do? And he has said this a number of times, including in front of the president, how we've worked with him even before he was governor. So that time I told him, it looks like we have to have a pathway of mediation. And that's how, through him, he called the governor, because I told him, somebody must take responsibility. It pains us a lot, first of all, that health workers must go on strike. And I am from that background. And it is because of lack of interest for citizen issues. And I think it's a bad thing. My cabinet secretary, Duale, has been accused so many times of favoring the union. But it's not about favoring the union. We have to treat healthcare workers right so that healthcare workers treat patients right. That is the only way we ensure patients don't die.
Thank you. I have been here with Dr. Davje Atela before, and even the union official for Kiambu. And it seems like the union are having difficult times dealing with the counties.
Yeah.
What are you doing as the minister officials in 30 seconds?
What we've done is that, and you've seen the leadership we've provided in implementing the CBA. We've given counties money. We just gave them 1.5 billion last financial year. We are giving them another 1.75 billion, again another 1.75 billion. UHC workers, you see, we have given them money. We've put them on salaries. The contracts, governors are still engaging, and the president has already promised he's going to give money so that we put them on proper contracts. In fact, since I came to the ministry, there's quietness. We've sorted out the CBA for clinical officers. We've sorted out the CBA for nurses. And I'll say this again. What people interpret as UHC is the interaction between the patient and the health worker. All these other things, or whatever you're doing, how the nurse and the doctor treats them, that's what they think is UHC is.
Thank you, Dr. Ray. And it has to take the president to come and explain all these things, whether SHA is working. You are only one person, and Duale is only one person. What are you people doing so that we use platforms such as this to disseminate information? These things that you are explaining here are very good. Kenyans need to hear this. And thank you for coming.
That's why I've come, my brother.
Thank you for coming, my brother.
So that we can use these channels, and you can call us anytime.
Thank you.
And we also want to work with a number of people, including the people you host, so that you can also ask them whether they are using SHA, but more importantly, whether they have paid up, more importantly, whether their villagers have paid up, because this is our collective Arambe. Without this, I can tell you for sure, you are better off having SHA and then calling Dr. Luga that I am here at Nairobi West, and they are telling me I need to add. Then I'll tell you whether there's another hospital, whether you don't need to add.
You are parting short, Daktari, as we are winding up, to the Kenyans who are saying that SHA is not working, those who are stranded, and those who still need the information. Please talk to them even as you look at this camera.
Thank you, Kenyans, for embracing SHA. Just 1 year, 27 million of you have gotten into the Social Health Authority, our collective mechanism to finance healthcare. Health is the most important thing you can ever have. Health is the most important thing. Everything else is important. Your work is important. Politics is important. Arguments are important. Saying SHA is not working is important. Until you get sick, then you'll realize SHA is working, SHA is important, SHA is what you ever needed, and SHA is what will take this country forward. Because under His Excellency President Ruto, he has anchored health not just for protection, but also for economic transformation. Thank you.
Thank you so much, Daktari, for finding time. And this platform is there. It's for the people. That is why we call it the People's Bench. We will partner with your office even to keep on giving such kind of information to Kenyans, because when Kenyans are protected, like you've said, we have a healthier country. Thank you so much for watching, and with that we've come to the end of our conversation tonight. It has been the People's Bench, coming to you from Muthu Silver Springs Hotel here in Nairobi, and brought to you by Fred Ogweno. Until next time, do not forget to subscribe, and until next time, bye bye. Thank you so much, Dr.
I am also
that
Fred.
was good. Oh, you also yes. Thank you so much for coming, Dr.
So much.
That was so good. We appreciate it. We do it again next time. Bye bye. Thank you.